recognizing that breast cancer results in death for African American women at nearly double. Pink Table Talk, Breast Cancer Risks and Realities.
And welcome to the second annual Pink Table Talk, sponsored by Kappa Alpha Sorority Incorporated, Xi Omega Chapter, in collaboration with the Pearl and Ivy Educational Foundation. I am Raven Hill, First Vice President and Program Chairman of Xi Omega Chapter and Vice President of the Pearl and Ivy Educational Foundation. On behalf of almost 560 members, I bring you greetings. Today is Breast Cancer Awareness Day for Alpha Kappa Alpha, and our opportunity to bring information that will both impact and empower the community we serve. We introduced Pink Table Talk last year to shed light on the risks and realities of this disease, and we are thrilled to offer it again. Today, we offer a special salute to all breast cancer survivors and those whose lives have been personally touched by breast cancer. As a reminder, we are simulcasting tonight's event on Facebook Live. Whether you are watching on Zoom or Facebook Live, we encourage you to share the event link from the Xi Omega Facebook page and on your own personal page. We want to make sure that we reach the broadest audience possible. Please post, share, and tweet using our hashtag #XOPinkTableTalk. Now it is my pleasure to introduce tonight's moderator, Tonya M. Brown. Tonya leads breast cancer awareness initiatives as Xi Omega's Women's Healthcare and Wellness Lead. She believes good health is a matter of mind, body, and soul. A psychology professor, Tonya is also a certified cycling instructor who takes great pride in not only losing 70 pounds, but maintaining a healthy weight for over the last 12 years. She is a fierce advocate for emotional and physical wellness and hosts a series of informative webinars under the Professor Brown banner. Without further ado, I will now turn the program over to Tonya.
Thank you so much, Raven, and good evening to everyone joining us via Zoom and Facebook Live. And good evening to our esteemed panelists. Our first panelist is Ricki Fairley, a stage 3A triple negative breast cancer survivor, thriver. Ricki's personal purpose, passion, mission, ministry, and blessing is to bring focus, attention, research, and action to eradicating Black breast cancer and supporting and coaching what she calls her breasties through their breast cancer experience. Ricki is an award-winning seasoned marketing veteran that has transformed her strategic acumen into breast cancer advocacy. Ricki recently co-founded Touch, the Black Breast Cancer Alliance, to address Black breast cancer as a unique and special disease state, with the overall goal of reducing the mortality rate for Black women. Ricki co-founded and serves as the co-host for The Doctor Is In, a weekly live web series on blackdoctor.org Facebook page. Please join me in welcoming Ricki Fairley. Good evening, Ricki.
I was on mute. You
guys,
that's okay. How are you guys? It's great to see you all. I love all the pink. Only I'm wearing orange because it's my logo shirt. Can you see?
Yes, it's beautiful.
And it's great to be here. And I'm so honored to talk to you guys. And I will tell you my story and then tell you some facts about Black breast cancer. And then you can ask me questions. Does that work? So I had triple negative breast cancer. I was diagnosed in 2011. I was your typical Black superwoman, as you guys are, taking care of everybody, you know, the mom, the breadwinner for my family, the rainmaker for my company, and flying all over the place, taking care of 2 kids. My youngest daughter was actually a sophomore at Dartmouth at the time, and my oldest daughter was working in the Obama White House. But I was a crazy person, just like you guys are. We never stop. We just take care of everybody. I got you. I'll do it. I'll do it. And so I got stopped in my tracks. I was diagnosed with triple negative breast cancer. I did a double mastectomy by choice. I did 6 rounds of chemo, 6 weeks of radiation, and then a year to the day, they found 5 spots on my chest wall. And my doctor at the time was pretty young, and she had only had 2 cases of triple negative. And I'll explain what that is. And I'll let Dr. Hampton explain what that is, what triple negative is, when it's her turn. It's the breast cancer with the subtype with the highest mortality rate and the worst outcomes. And so I'm a walking blessing. But they told me it came back, and they said, we're going to put you back on chemo. My doc at the time was a baby. She was 38. She had only had 2 cases of triple negative, and both of the women died after 9 months. So she was really nervous. And so we ended up going to Emory to a triple negative specialist and to figure out what my treatment plan would be. I went back on chemo, and then a few months later, I had implant surgery, and the cancer was gone. So we don't really know why. I'm a walking miracle. God intervened and left me here to do this work. So I really feel like it's my purpose, and that's what I do every day. I fight like a girl every day. I've come to learn over the years of advocacy, and I serve on the board of the Triple Negative Breast Cancer Foundation, and I do a lot of advocacy for pharmaceutical companies. And I've come to learn that Black breast cancer is its own disease, that we have our own disease as Black women. We don't have the same disease that white women have. And why is that? Really because we are dying at a 42% higher rate than white women. Black women under 35 get breast cancer at twice the rate, die at 3 times the rate. Our breast cancer recurs at a 39% rate versus 20% for white women. 21% of Black women with breast cancer won't make it 5 years. That number for white women is only 8%. So the numbers, and I could go on forever with the numbers, you can look at them on my website, but the numbers are devastating for Black women, and it's really the most devastating disease that we face. The only other one that's really bad is heart disease for us, but the numbers for mortality are crazy, and we have to stop it. There are a lot of psychosocial factors why Black women are different, and you guys know those, the social determinants of health, and a lot of us are single moms, and we take care of everybody, we don't have health insurance, all those things, but I really believe that our physiology is different, and right now the drugs that are on the market were made for white women, and we don't have any drugs that really are made for our bodies. A lot of us have triple negative breast cancer. We get it at twice the rate, 2.3 times the rate of white women. It's very associated with the BRCA gene, which we are more likely to have. I don't have the gene, right, Dr. Hampton? We checked that out, but I think that there's probably a gene that for Black women that we haven't uncovered yet. So I really started my foundation a few months ago because I want to bring the science to Black breast cancer. And it's really, I want to get pharma involved. So 20 years ago, if you think about it, the AIDS community went after pharma with a vengeance and said, we're all dying. We're dying from illness. We don't even know what it is. We have sex and we die. So can you fix it? And they did. And Magic Johnson's still alive. And now you can go undetectable with AIDS. So why can't pharma do the same thing with Black breast cancer? So that's kind of my challenge to them. And I also learned that I can't do it alone, that Komen can't do it alone, that LBBC can't do it alone, that Dr. Hampton can't do it alone. None of us can do it alone, that we really need an alliance to work together towards this common goal. And so I'm working really hard to partner with other breast cancer foundations and organizations and pharma companies to kind of march down this yellow brick road together to solve this problem, because no one can really do it. And I don't want to minimize the work that's been done for so many years by so many organizations. Breast cancer has more advocacy groups than any other disease state. And we're all working really hard. And I think we can all go to bed at night and pat ourselves on the back and say, I did a good job today. I gave a hug. I took somebody to chemo. I made somebody dinner. I came up with a new drug. But unless we really kind of put our resources together, we're not gonna crack this nut and solve this problem. So I'm all about trying to figure out how to eradicate Black breast cancer. I have 2 precious grandbabies, 1 and 3, and another one on the way. And I don't want them to ever speak the words breast cancer. So I try to work really hard to kind of pull our ecosystem together to get rid of this disease. I left out one part of my story, which I think is really important for you guys. So when I got breast cancer, I quit my life and started a new one. And I had to come to learn, being a crazy control freak Black woman, as you guys all are too, that I couldn't take care of everybody, right? That I had to figure out how I could just take care of myself. And I knew I had to take care of my baby daughter, Haley. And so I went to my first meeting with my nurse navigator. I walked in the door and she said, "Ricki, you are so stressed out." And I said, "I don't believe in stress. Stress is for wimps. Who has time for stress? What am I going to do? Not go to work, not feed the kid? What am I going to do?" And I said, "Well, how do I know I'm stressed out?" And she said, "Well, how many times a day do you either think or say the word asshole?" And it probably was a lot. I didn't really say it out loud a lot, but in my head, that was my name for both my husband of 30 years and my business partner of 10 years, usually with a couple of adjectives. I won't say what they are. So I had to learn that not only did I have to get rid of the cancers in my body, but I had to get rid of all the cancers in my life. And I had to learn that my peace is non-negotiable. And I really made decisions to choose life. So while I was on chemo, I quit my business partner, started my own company. And my first client, I was a marketing person. My first client was Obama. I made all the radio ads for the 2012 Obama campaign. I divorced my husband of 30 years. I sold my big house in the suburbs in Alpharetta, Georgia, and I moved to the beach, to a little 1-bedroom condo. I wouldn't recommend that when you're on chemo to do all that. But I realized that I had to choose life every day. And I had to find peace and learn that my peace is non-negotiable and so is yours. And so as Black women, we take care of so many people, our moms, our kids, our aunties, our matriarch, and we're all, all in it every day, doing everything for everybody. But you have to stop and take time for yourself and check your breasts. We can't prevent breast cancer, but we can early detect it. And so check your breasts every month. If you need a reminder, I'll remind you. If you follow me on Twitter and Instagram, I'll remind you on the 20th of every month, which was the day of my mastectomy. My Twitter is @RickiDove, and my foundation Twitter is TouchBBCA, and my website is touchbbca.org. But we have a lot of.
Thank you so much, Ricki. I did want to say this because I know you have another event. Can you just give us a brief overview of triple negative breast cancer?
Sure, and I'm going to yield to my doc, but so basically there are subtypes of breast cancer, many types, but there are kind of 3 main types, and it's really kind of how your body receives treatment. So one is about estrogen, one is about progesterone, 2 hormones, one is about HER2 and enzyme. If you test negative for those 3 things, then it's called triple negative. So we're the only breast cancer that doesn't have a drug to prevent recurrence. You may have heard of tamoxifen or something that you take for 5 years. We don't have a drug. My drug is God and paddleboarding and seeing my grandchildren, but we don't have a drug. We recently now have 2 drugs on the market for metastatic triple negative that have just come out in the last year. And so they're doing wonders in saving lives. But that's the first drug ever in the history of the disease. We have another drug that's on the way called Keytruda, and it's a drug by Merck that basically is being used in other cancers, and it's about to go on the market for a triple negative, which will be for early stage triple negative, which will be a first in the history of the world. So it's a nasty disease. It has a really high mortality rate. Most of the women that had what I had, I don't know them. They're not here anymore. So I feel very blessed to do this work. I know it's my passion, my purpose, and I wouldn't know how to do anything else.
Thank you so much, Ricki. Thank you for joining us. We know that you have a full evening this evening. You have 3 events, and we thank you for making Zalmega your first stop. God bless you and stay well.
Can I say one more thing? We're doing
Sure.
We're doing a Halloween walk. If you check out our website, you can find the information. And we're doing a breasty takeover. We're going to take over Black Friday and be Breast Cancer United. All of the breast cancer organizations are going to walk. So I'll send you some information to spread around. But I'd love for you guys to walk with me.
We would love to. Thank you for joining us.
Thank you. Take
Thank
care.
you.
And Dr. Hampton, you do a better job for them when you get to triple negative. Well,
Thank
bye.
you.
My gosh.
Bye-bye.
Bye. Bye-bye.
And our next panelist, Dr. Dorian Thomas, is a radiologist, entrepreneur, and business owner of Laurel Radiology Services in Laurel, Maryland. After working for several well-established radiology practices in the Washington, D.C. area, Dr. Thomas decided to use her expertise in radiology, business, and commitment to quality care, as well as her desire to personalize her practice to needs of patients by establishing Laurel Radiology Services. In addition to providing outpatient services, Laurel Radiology Services provides imaging to several local hospitals. Dr. Thomas is a member of Alpha Kappa Alpha Sorority Xi Omega Chapter. Please join me in welcoming Dr. Dorian Thomas. Good evening, Dr. Thomas.
Good evening. Thank you so much for having me. Very honored to be a part of this program.
Thank you. So, Dr. Thomas, we had some preliminary conversation, and you really wanted to highlight the topic of African American women and dense breasts. So let's just get right to it. First, what are dense breasts, and how do you know if you have them?
Well, let's start by saying that radiology, and particularly in mammography, density matters. And so when we talk about the density of the breast, we're really talking about the amount of fibroglandular tissue versus fatty tissue. And that's really important, particularly for evaluating mammograms. We know that about 40% of women have dense breasts. And in radiology, when we look at a mammogram, we're looking to see the density of the breast and our ability to be able to detect cancer.
Okay. And what are the different categories of breast tissue?
When we look at the mammogram, the radiologist is really looking at the amount of fibroglandular tissue versus fatty tissue. So there are essentially 4 categories of breast density that a report will have on the report. The type of density that's on the report. There is the almost entirely fatty breast, which is that breast which is almost lucent. It has very little breast tissue, less than 25%. The next category would be what we call scattered fibroglandular elements, and that would be breast tissue that has density which is about 25 to 50% fibroglandular tissue. Number 3 would be considered heterogeneously dense, which is about 50 to 75% fibroglandular tissue. And then the last category is that really dense breast, extremely dense breast tissue, which is about 75% or greater of breast tissue.
Thank you, Dr. Thomas. Why are women with dense breasts at a higher risk for cancer?
Well, in general, because there's more breast tissue, there's more opportunity for cancers to occur. And secondly, when we're looking at the mammogram, as we were referring to as density, the amount of fibroglandular tissue is the type of fibroglandular tissue that you have. If there's a large amount of breast tissue or fibroglandular tissue, which is white on a mammogram, the cancer looks white. So you can only imagine when you have a lot of fibroglandular tissue and the cancer looks the same as it's dense, then it makes it even more difficult for us to detect breast cancer.
Thank you, Dr. Thomas. October 16th is Mammogram Awareness Day. Please discuss the critical need for women with dense breasts to get mammograms.
Well, that's a very interesting topic because I hear a lot of patients say, well, I have dense breasts, so why do I even need to get a mammogram? Well, mammography doesn't just detect masses for cancer. There are also other things that we look for when we look at a mammogram for cancer. We're also looking to see if there are any ancillary signs of cancer where the breast, where there may not be a mass. There may be calcifications, which are basically small calcium deposits that can occur in the breast without necessarily having associated mass. There can be the distortion of breast tissue that may also be a sign of breast cancer. There could be skin changes, nipple changes, changes in the armpit where there are lymph nodes. So even when a patient may have dense breasts, it doesn't mean that you should stop doing a mammogram. There are other things that we use just besides masses. And in conjunction, we are also now using screening ultrasound, because ultrasound can actually detect cancers, about 2 to 3 additional cancers that may not be seen on a mammogram on this ultrasound. So that is why we are using now supplemental ultrasound for women that have dense breast tissue, because we may not be able to see all the cancers on the mammogram, and ultrasound allows us to dig a little deeper, sort of to go through the trees a bit in order to see the cancers that you may not be able to see on the mammogram.
Thank you so much. Laurel Radiology Services has acquired mammography equipment called ABUS, which is the only breast cancer screening technology FDA approved for detection in women with dense breast tissue. Tell us about ABUS and how you're using it in your practice.
Yes, we recently acquired ABUS, which is the acronym for Automated Breast Ultrasound. And what that allows us to do is really to screen women who have dense breasts. Even when you can't see anything on the mammogram, you may be able to detect that 2 to 3 additional cancers that you may not be able to see on the mammogram. This is a ultrasound transducer. It's a fairly large transducer which has an extended arm that systematically goes over the breast in 3 different projections, and then it actually recreates the breast in a 3D image, where we will then be able to look at that 3D image and narrow down and see a cancer. So in these particular ultrasound cases, the patient cannot have, usually they're asymptomatic. There is no associated symptoms with pain or a lump. They really have to be asymptomatic before we would do the ultrasound. Let me just go back a little bit about the automated breast ultrasound. We really chose this. We're the only one in this area in the DMV, because I really felt very passionate about, detecting cancer. Particularly in the African American community, we may lag behind some of the more advances, and so we really thought this was something we wanted to bring to the community. It was a big financial outlay, but we think that this will really help in trying to improve and increase the amount of cancers that may be undetected by just doing mammography, even with 3D mammography. When we send out letters to patients, they will find out whether or not they have qualified for the examination. It's usually, it may or may not be covered by insurance companies. There are some insurance companies that will pay for it. There are others that will not. And there's certain states that actually require all insurance companies to actually provide the service without any sort of outlay by the patient in order to have the examination. But unfortunately, in the state of Maryland, that legislation has not come to fruition. So patients may find themselves in a position where we may recommend a screening mammogram, and there will be something that they would have to pay out of pocket. But we find that this is a very helpful tool. I have found since we got started in June, I have found 2 additional cancers that I did not see in retrospect when looking at the mammogram. So we think this is something that is going to be a game changer for our community and women throughout the DMV. So I'm excited about it. We're looking to bring it to those patients who have gotten a mammogram but have the dense breasts and didn't have any other alternatives to look further.
Thank you so much, Dr. Thomas. And can you please tell us how we can get in contact with Laurel Radiology Services to schedule our mammogram, our ultrasound, or any other services that we may need? And we'll type that information in the chat for our attendees.
We are in Laurel, Maryland, and we are on the web, and it's Laurel Radiology. We're Laurel Radiology Services in Laurel, Maryland. Our website is www.kappalrad.com. And so you can reach us through that, through any of those, those connections, either through the internet or through just calling us and making an appointment.
Thank you so much, Dr. Thomas. And ladies and gentlemen who are joining us, if you have any questions for Dr. Thomas, please type them in the chat. Please type them on Facebook Live. And when we get to this segment for question and answer, we'll bring Dr. Thomas back in to answer your questions. Thank you, Dr. Thomas.
Thank you.
You're very welcome. Dr. Regina Hampton is the medical director of the Breast Care Center at Doctors Community Hospital, the first breast center in Prince George's County. She is a board-certified general surgeon who has focused her practice on breast health and breast cancer. In addition, she is the only trained hidden scar surgeon in Prince George's County and east of the river. Dr. Hampton is also the medical director and co-founder of Breast Care for Washington, a nonprofit dedicated to providing access to mammograms regardless of ability to pay. In October 2018, Dr. Hampton opened Cherry Blossom Intimates at Woodmore Town Center. It is a bra boutique offering custom prosthetics for breast cancer survivors and lingerie for all body shapes and sizes. Please join me in welcoming back to Pink Table Talk 2020, Dr. Regina Hampton. Good evening.
Hi, good evening. Thank you. Thank you for having me.
You are very welcome. Dr. Hampton, how has the COVID-19 pandemic impacted surgery for breast cancer patients?
So when COVID-19 hit, all hospitals actually shut down the operating rooms to what they call elective surgeries. Now, people would say, well, with somebody with cancer, is that really elective? What we did is for the patients who are estrogen and progesterone positive, we went ahead and put them on their hormone medicine, which we typically would give that to them at the end of all of their treatment and leave them on it for 5 years. So we pre-treated them while we were awaiting COVID. And then for our patients who are triple negative, as Ricki described, some of them actually we went ahead and did their surgery. Some of them we went ahead and did their chemotherapy first. And so now we're all caught back up. And I think one of the challenges are the folks who weren't able to get their mammograms. So I think we're still all catching up and trying to get those folks back on schedule to get their mammograms.
Thank you so much, Dr. Hampton. Dr. Hampton, you are the only trained surgeon for the hidden scar procedure in Prince George's County and east of the river. What is the hidden scar procedure?
So when we used to do breast surgeries, particularly lumpectomies, everyone was just focused on getting the cancer out. So we did a good job with getting the cancer out, but the breasts looked horrible. I mean, they just didn't look good. I mean, I've seen patients where sort of half the breast was missing, and it kind of begged the question, well, what are we saving the breast for if we're not going to make the breast look like a breast? In addition, we know that many women are going to survive for years and decades beyond their diagnosis. And so it's important that they not have a reminder of where their surgery was. And so hidden scar surgery is really being conscious about scar placement. So I try and hide it around the areola, which is the dark part around the nipple. I try and hide it under the breast. There are times when I have to go under the arm to take out lymph nodes, and I can access the cancer through that same incision. So it's really being conscious about scar placement so that the woman doesn't have to view that scar for the rest of her life. And then it's also in bringing the tissue back together, because that's what decreases the risk of dents in the breast. I tell my patients, we're not going to do denty breasts on my watch. So I like to bring the tissue together. And then there are some patients where if they have a larger breast size and sometimes a larger cancer, we would have typically had to do a mastectomy and remove the whole breast. Well, in those cases, we can work with the plastic surgeon. In some of those cases, we can do a breast lift or a breast reduction. We'll do it on the non-cancer side. And then she just looks like she had a breast reduction. So she really doesn't have to think about an extra scar where her cancer was located. So it's really just thinking differently about how we perform the surgery. And I often like when my patients come in, and even me, when I see them years later, and we're both kind of trying to remember where the surgery actually was performed. So, to me, that's just how it should be. And there are a lot of surgeons across the country that have adopted that method. I didn't create it, but have adopted the method of trying to hide the scar so that patients can live their lives and not have to think about the fact that they had surgery or that they had cancer.
Thank you. So Ricki asked me to come back to you and have you elaborate and share more details about triple negative breast cancer. Can you do that for us?
Absolutely. So as Ricki said, triple negative breast cancers are cancers that are not responsive to hormones. So if someone has a hormone responsive tumor, meaning the tumor likes to use estrogen and progesterone, and it kind of uses it as food to grow. Well, we have hormonal medications. Tamoxifen was the first one that was out. There's another class of medications called aromatase inhibitors. And what those medications do is they block that hormone receptor on the cancer cell. Doesn't block the hormones for the woman because we need our hormones. We love our hormones. But it blocks the cancer cell from being able to access any hormones. So after we've taken the cancer out and treated the cancer, we'll put the patient on that medication for the next 5 and sometimes 10 years because it's going to block that receptor on any new cancer cells that decide to form. So that's protective for those women. When you have triple negative, you don't have that receptor. You don't have an estrogen receptor. You don't have a progesterone receptor. And there's a third protein called the HER2 protein. The triple negative patients don't have that either. So usually we're going to treat them with chemotherapy and or radiation and surgery in most cases. And then we're just going to follow them with mammography and clinical breast exam. We don't have a pill that we can put those patients on for the next 10 years to try and prevent their cancer from coming back. I think one of the big wins in triple negative is that we've changed the way we deliver the chemotherapy. So typically women used to have surgery first and then get the chemotherapy. Well, what we've realized is chemotherapy is the most important treatment for that patient. So we usually give that medicine early. And even if they have a smaller cancer, I tell patients, look, this is the most important treatment for you. Whether I give it to you before surgery or after surgery, let's get it in now, and then we can come back and do the surgery later. The benefit of that, and what we found, is that the triple negative cancers are some of the best responders to that chemotherapy when we give it before surgery. So it's great because many times I'm going in, all I'm taking out is the biopsy clip that the patient might have gotten from Dr. Thomas when they had their original diagnosis. And many times when the pathologist looks at the tissue, there's no cancer left. So that's one of the exciting things about triple negative. It is still one of the aggressive diseases, but we get that aggressive treatment in early, and we're starting to see better outcomes.
That's very hopeful and positive to hear. Thank you for sharing that. Dr. Hampton, you are also the co-founder of Breast Care for Washington. How does Breast Care for Washington work to meet the needs of uninsured women who need mammograms?
So we formed Breast Care for Washington because in Ward 7 and 8 east of the Anacostia, there was really a problem, and they had a really high mortality rate when compared to the other parts of the DC area. And so I wanted to take action and do something about that. And so we were fortunate to partner with Hologic to get a 3D mammography unit, because I told them, look, I'm not just going to put any 3D machine in the community. We need to put the best. If they can get 3D over west of the Anacostia, we need them to be able to get 3D east of the Anacostia. And so we were fortunate in that partnership. And so we offer 3D mammography, and we don't turn any woman away. So whether she has insurance or not, we make sure that we take care of her. We get the biopsy done. If she gets diagnosed, then we've partnered with some of the breast cancer centers in the DMV area to make sure that they get navigated into treatment. And then also last year, we were fortunate to get a mobile mammography bus. So now we have that to take it to the streets and meet people where they are.
Absolutely. Dr. Hampton, let's talk about Cherry Blossom Intimates, your boutique at Woodmore Town Center. Tell us your story and how you have fared during the pandemic.
So I think kind of as with everything I've done, whether it was starting the breast center in Prince George's County, starting breast care for Washington, it's always just been a need. And I feel like no one's really taken the needs of women of color and wanted to meet the need. So I had this idea to do a bra store, didn't know how I was going to do it. Many of the women who come into my office are in the wrong bra size. And so I happened to be at a breast cancer walk, and that's where I met my business partner, former Miss District of Columbia, Jasmine Jones. And then so we partnered to create Cherry Blossom Intimates. And I think what's unique is that we serve all women. And so we're a retail store, but within it, we're an accredited mastectomy boutique that's accredited by CMS Medicare. And so we have women who come in and we do the fittings, we take care of the billing, really try to make it a seamless, frictionless process for the women who've already been through so many challenges in their breast cancer journey. The other thing that I really wanted to address was, I got tired of my patients coming in with pink prosthetics. So someone my color with a pink prosthetic just was not working. And I got upset. I called a couple of mastectomy stores and said, why are you giving my patient this? And they just didn't really take the time to even order a prosthetic that meets the color of one's skin. So that was the other need. And I found that there wasn't a place in Prince George's County that really was meeting the needs of women. So it really just came out of meeting the needs of women. And I thought it was, it's just for my patients. But I realized that patients that go to some of my colleagues, they were having some of these challenges as well. And then we do custom prosthetics, so we can color match anyone's skin tone, about 31 different skin tones. Because I say even white women are not white or pink, they have different shades and tones to their skin as well. So it's really about just meeting the needs of all women, all shapes and all sizes.
Thank you, Dr. Hampton. At this time, we're going to transition to our question and answers segment. And I'm going to bring in Brianna Blakely Henderson, who is the Ivy Leaf reporter and public relations chairman for Alpha Kappa Alpha Sorority Incorporated, the Omega chapter. And Brianna will read the questions that are typed in Facebook Live, and she will also assist me in reading the questions in the chat via Zoom. Brianna?
Hi. Good evening.
Hi.
You guys have been amazing tonight. So far, we don't have any questions on Facebook Live, but there's plenty of questions in the chat.
Okay.
So the first question in the chat is there anything we women can do to lessen dense tissue in our breasts? This question is from Angela McKinney.
Hi, Angela. That's a great question. There is really nothing that we can do about the density of our breast. Remember, it's not a disease. It's just something that the type of tissue that we have, an amount of, like I said, fibroglandular tissue versus fatty tissue. And the only way that really changes is really with age. Oftentimes, as we get older, the breast may become more fatty, and also with weight gain. With weight gain, the tissue may become more fatty. And I've actually seen where women who have had fatty breasts as a result of losing weight, their breast actually appears more dense. So there's really nothing that you can do about the amount of density that you have, other than some of the physiologic changes that occur with weight gain or as we get older.
Thank you. Dr. Hampton, Sierra Edwards typed the question. She said, how can women best check their own breast at home just to be consciously aware?
So what I tell women is you want to learn what your normal lumpiness is. As Dr. Thomas was talking about dense breast tissue, it's, if you think of it as when you do your breast exam, it's sort of the lumpiness that you're feeling. All that lumpiness, once it's compressed on the mammogram machine, is going to look like breast density. And some of us are going to have varying degrees. So instead of being afraid to do your breast exam, think of it as, I'm just learning what my normal lumps feel like. And it'll become a pattern and you'll learn what it is. And the only way to know if something feels different is you got to learn what feels normal for you. So doing it 7 to 10 days after your menstrual cycle. For those of you who are not menstruating anymore, just pick a day of the month. I say use your birth date and check your breasts the same time every month. And then if something feels different, don't panic. Give it maybe a week. Check it out again. If it doesn't go away after that time, then call your doctor and get an exam and possibly get some breast imaging.
Thank you. Brianna?
Yes. Renee Diggs on Facebook Live asks, does breastfeeding have an impact on breast cancer? Does it lessen or increase the likelihood of breast cancer? And a few years ago, I was told that I should test for the BRCA gene because my likelihood of carrying the gene was high due to the number of women in my family who have been or were diagnosed with breast cancer. I haven't because I was told to wait until I was done breastfeeding. When is a good time to receive the test?
So I'll take the first part. So it's important to get what we call a risk assessment, where a clinician can really dive deep and find out, because it's not only was there any breast cancer, but the age makes a difference. So if there are women who have breast cancer at younger ages, particularly under age 40, which typically African-American women can, then we want to start screening the women in that family a lot earlier, usually at least 10 years earlier than the earlier diagnosis. So if grandma or mom or sister were 41, we should start screening the women in that family starting at about age 30. Actually, and Dr. Thomas may comment on this, the ACR and the Society of Breast Imaging came out 2 years ago and said, African-American women just as a whole are considered high risk. And so we should be undergoing high risk counseling to determine if we need to start screening before the age of 40. And so I don't think enough of us talk about that. I think it's important that women look into that, speak to a clinician and see if maybe you should start some type of screening, whether that be with ultrasound, clinical breast exam, mammography, and in some cases, breast MRI. And then the second was about breastfeeding. So breastfeeding has been found to be protective and help to decrease one's risk for breast cancer, but it's not an absolute, because we still do see women who have breastfed who do develop breast cancer, but breastfeeding is considered protective and helping to lower the risk for breast cancer. It's also good for the baby too.
Right. And I would say in regards to imaging with women who are breastfeeding, we will not deny a patient from having a mammogram that has a palpable lump during breastfeeding. What we will ask them to do prior to the examination is really to express their milk. One, so that they have lessen the density of the breast when we actually do the imaging. Also, after the examination, they'll have breast milk for the baby, and then they can resume doing their mammogram, or they can resume doing breastfeeding after their mammogram, and they'll have the breast milk available for the baby. But we do not deny doing an imaging exam when a patient is breastfeeding, even though the breast tissue may be a little bit more dense during that time. And if there's something that is palpable, also we'll do an ultrasound, because oftentimes it's not always cancer, as Dr. Hampton alluded to, is it may actually be a cyst. It could be other things that occur as a result of breastfeeding, with such entities as galactoseals, which is kind of a milk-forming mass, or lactating adenoma. These are all masses that occur normally or can occur while you're breastfeeding. And it can be difficult to differentiate. So it does not preclude from having a biopsy if there is a palpable abnormality that is seen during breastfeeding. So we do not say we don't image. We will image, but we will put certain things in place to make sure we can minimize the density of the breast by expressing the milk.
Thank you.
I just want to make a comment about family history. It is so important that in our African American and Latina families, we have to really start talking about illness, breast cancer, colon cancer, mental health. We need to know who had cancer and at what age. When you look across cancers, we typically get most cancers at younger ages. We just saw Chadwick Boseman. So we've got to talk in our family. So I would challenge everybody at your next family reunion, Zoom family reunion, that you do something so that you can collect the health and medical history of your family members, because it really can be life-saving for the future generations.
Thank you.
And I would agree with that. And it's not just on the maternal side, also the father side as well, because there are men that get breast cancer as well. And so we do have patients whose father may have had breast cancer and they also have it. So, but also remember that we are women. So even if we don't have a family history, that makes us at risk for getting breast cancer. So I hear patients often say, well, there was no one in my family that had breast cancer. Well, we have breast tissue, which means that we are prone to get cancer. So I agree with Dr. Hampton wholeheartedly. Get the history, but don't, it's just because you didn't have the history doesn't mean that you can't get the cancer.
And Kimberly Golden's question ties perfectly into your last statement. Good evening. For women under the age of 40 with a family history of breast cancer, what is the recommended screening modality, ultrasound or mammography?
Well, with the women under that age, we usually start with a mammogram, with a sonogram. But if there isn't anything there, that does not stop us from going to the next level, and that would be a mammogram. So if a patient comes in and they say that they're having pain or they have something palpable and we don't see anything, even though they're a young age, that does not prevent us from going on to the mammogram. Remember, mammography is very low dose, and everyone does get concerned about radiation, but you can get a lot more radiation just from flying an airplane than you can from getting a mammogram. So the fact that it does have radiation doesn't mean that that you should not get the examination.
Thank you. Brianna?
Anita Cook Wells asked on Facebook Live, do you need to continue to have mammograms after a mastectomy and reconstructive surgery? Does it make a difference if you use natural tissue in the reconstruction?
So we don't do mammograms after mastectomy. So if a woman has had mastectomy on one side, we will only image the other side that's remaining. But we do still recommend doing clinical breast exam and doing breast self-exam on the side where the breast tissue was removed. As far as reconstruction, there's so many different options for reconstruction. And it's really about having a good plastic surgeon that you can have a conversation with. There's some options that are better for some women than others, but it really is a personal choice. There's some women who just don't want to have an implant. There's some women who are fine with an implant. So I think the great thing is there are many options. It's not a one size fits all. And so it's really about having that conversation and finding out the option that's best and safe for you.
Thank you. Dr. Thomas?
Yes.
Victoria Person asked if she wanted to come to Advanced Lower Radiology Services for the A-bus screening, would she need a referral?
Yes, she would. She would need a referral for the A-bus, unless she's paying it out of pocket. Then then she would not necessarily need a referral. But for most cases, you would need a referral. Now, remember with screening mammograms, you do not necessarily need to have a referral. As long as you have a physician that we can send the report to if it's abnormal, you don't need to have a script. Generally, for the screening ultrasound, you do need a script unless you're paying out of pocket. Then if that's something that you want to do, then that's certainly something that we would offer.
Thank you. Brianna?
There are no more on Facebook Live at this time.
Okay. Tamalyn Smith said to Dr. Hampton and Dr. Thomas, what are your thoughts on 3D mammograms?
So I think 3D mammograms or digital mammograms are really the best way to go. I think especially when you have dense breast tissue, I always say, as someone who has to evaluate these patients, I want the best picture possible. So if they can go to a good place and get good imaging that, I can take a look at and help me to determine what's going on. I personally am a big 3D mammogram advocate. I think it really helps us to give us a better picture, just gives us a little extra layer. It's sort of like peeling away pages in a book. So you can see the cover and the back cover, but sometimes there's juicy stuff in the book that you want to know about. So a 3D mammogram is like you're taking and you're flipping open the pages of the book, and there on page 57, there might be a cancer there that you might not have seen if you were just looking at the outside. So 3D mammography offers that insight into looking at the breast. It can find up to 40% more cancers at a earlier stage. And it can even decrease the callbacks. So many women who have lumpy, bumpy, dense breast tissue oftentimes have to get an ultrasound on top of that. And in some cases, they can get the 3D mammogram and not have to get that additional imaging. So I think it just offers options for women.
Thank you. Dr. Thomas?
I don't think I have anything more to add to Dr. Hampton. I think she explained it very well.
Okay, thank you. Brianna?
Lee Marie Thompson asks on Facebook Live, can you elaborate on paternal side breast cancer? What's the difference between paternal and maternal side cancers?
So when we're talking about, maternal is our mother's side and paternal is our father's side. And again, you want to drill down on who had the cancer on either side and what age. So as we know, men can get breast cancer. Men can also carry the BRCA gene, and they can pass that gene on to their daughters and sons. So it's important, as we were saying earlier, to really find out the history on both sides of the family, that helps us to determine what the risk is and whether we need to, start following those women a lot more closely. Matthew Knowles is a BRCA2 mutation carrier, and he recently had male breast cancer. So we oftentimes forget that men can get breast cancer. Men have breast tissue. Some men have more breast tissue than some women, but it's important to evaluate, and especially if a man has a history of breast cancer in his family, it's important that he be aware as well and do breast self-checks as well, just as women do.
Thank you, Dr. Hampton. And Dr. Hampton, Patricia Cutler asked, may the patient ask for the entire breast to be removed if it isn't part of the initial treatment plan?
Yes, they can. That it is having the breast removed is an option. There's some women who are a candidate for lumpectomy, meaning just taking the lump out. And then there are some women who are not candidates for lumpectomy, and we may recommend mastectomy. And then we'll look at things like family history. Do they have the genetic mutation, the BRCA gene? And in some of those cases, we may strongly recommend that they have one or both breasts removed. So I think the great thing about where we are now is women have options. And just because one has breast cancer doesn't automatically mean that we have to remove the breast. So it's again, just having that doctor that you can have that honest conversation with. I have a lot of women who come in and they have just a stage 0, little small, half a centimeter of abnormality, and they may choose to do one or both breasts. And so it's just about them understanding also that even if you remove both breasts, your risk for future cancer is not completely 0. So it does go down to about 0.5% per year, but we have to make it very clear that they understand that they're not automatically free and clear. It's low, but not completely 0.
Thank you. Brianna?
Callie Keller she specializes in cancer rehabilitation, and she wants to know, what are your thoughts on physical therapy for women with breast cancer? Are you referring patients to physical therapy during and after cancer treatments?
So I think, cancer surgery has changed so much. So, typically, sort of back in the day, people would be admitted to the hospital a week before, then they'd have their surgery, then they'd be in the hospital for 3 to 4 weeks doing limited motion. For me personally, I encourage my patients to start movement immediately after surgery. I rarely even keep people in the hospital. So my limitation, if they haven't had reconstruction, is, they can continue to use the arm, just not to lift anything heavier than 10 pounds. So I'm really a big advocate of early movement after surgery. If I find it's a patient that is sort of nervous and limiting, then I will send them for physical therapy. But, I really try and encourage the patients to try and get back to normal life after their surgery. So I will recommend in the appropriate indications.
Thank you. So we have time just for 2 more questions, and I'll read a final question from the Zoom chat. Amelia Benka wrote, can Dr. Thomas speak more about breast calcifications? Are they similar to the calcifications in the vessels? Are they associated with diet? How do we prevent them?
That's a great question. Breast calcifications can occur anywhere in the breast. And as she mentioned, they can occur in vessels, which can make it sometimes difficult to differentiate from those calcifications that may be associated with ductal carcinoma, or calcifications that occur in ducts. We can also see calcifications that can occur in benign lesions. If a patient has had trauma to the breast, where they may have had some injury to the breast, they can develop calcifications, what is known as fat necrosis. So there are various types of calcifications that can occur, and we're looking specifically to see how these calcifications are they in a cluster, meaning are the calcifications in like a little group? What is the configuration of these calciums? Does it have some sort of linearity? Does it have branching? All of the things that we look for to see whether or not they have a configuration that suggests that they are cancerous. So it's a great question, and as I spoke to earlier, with the dense breast, if you're not able to see the masses, you may see the calcification. So when patients ask me, why should I get a mammogram if it's so dense and you can't see anything? Well, there are, like I said, other findings, and calcifications are deposits that can occur in the breast, particularly in instances of cancer. So that was a fantastic question.
Thank you. Brianna?
There are no more questions on Facebook Live.
Okay, thank you. So before we bring in April Gaines Jernigan, president of Alpha Kappa Alpha Sorority Incorporated Xi Omega Chapter, I will just have Dr. Hampton and Dr. Thomas leave us with words of inspiration, something positive that you want to share with us as we close out tonight's webinar. Dr. Hampton?
So I thank you so much for the opportunity. A lot of great information. So just want to encourage women to just, put your health first. As women, as Ricki was talking about, we often put ourselves on the back burner, and where we take our kids to the doctor, we make sure our husbands and partners, but we really need to put ourselves first. Check your breasts, know what feels normal for you. If something feels abnormal, don't be afraid to get it checked out. Continue to, strive to do the best and be the best for you and your family.
Thank you, Dr. Hampton. Dr. Thomas?
I have agreed. This is we're in a day and age where we really have to start taking care of ourselves. One of the reasons why I chose radiology is because I really wanted to commit to a service where I could help women. One of the challenges that I often find is really discussing with women, when they do have an abnormal mammogram, and it's really what I found. It's important how we discuss the results, and I have found that it gives me a great feeling when I'm able to allay the fears when you have to tell that patient that they have an abnormal mammogram, and not to put my famous words, or don't put the cart before the horse. Let's just take it one step at a time. So I encourage women to, take care of themselves, to get their mammograms. It should not be something that you should fear. is something that you should embrace. Take every month, as Dr. Hampton says, choose a day that you're going to examine your breasts. Choose a day of the year that you're going to get your mammogram. Choose a day that you're going to get your clinical breast examination. Don't be afraid. We're all in this together. And Dr. Hampton and I are, here to help you in any way that we can. This is our passion. This is how we like to take care of our patients, to make a difference. And thank you for having us on the program.
It is our pleasure. Thank you. April?
Yes, good evening. Thank you for participating in our second Pink Table Talk. What a wonderful discussion we had tonight on breast cancer risk and realities. Dr. Hampton and Dr. Thomas, your remarks were insightful. Thank you also to Ricki, who was with us earlier. Also, Tonya, thank you for ensuring that we covered all risks and realities about this disease. Tonight, we join with members of Alpha Kappa Alpha Sorority from around the world, as together we are raising awareness about breast cancer in our community and on this AKA Breast Cancer Impact Day. Thanks to each of you for helping Xi Omega to raise awareness about this disease in our community. Continue to be safe, wear your masks, social distance, and make your plans to vote now. Our vote is needed with our voice. I'd also like to remind you that there's an evaluation that you can take for this program, and it's tinyurl.com/XO Pink Table Talk. Thank you very much and have a great evening.
Thank you so much for joining us via Zoom, Facebook Live. Please remember to click like and share our video. Until next time, be safe and God bless you all. Good night.